Okay, I think just to get started, hi, welcome everyone. And I think I'm just going to get started since I have a few minutes of preliminary remarks and that will give other people a chance to join. And it is just such delight to see all of you on this, what is a very beautiful day here in Boston. I'm Sarah Altschuler. I'm Associate Professor in the English Department at Northeastern University, where I'm pleased to welcome you also as the Associate Director of the Humanities Center and Director of Health, Humanities, and Society. This lecture is generously funded by a year-long grant from the National Endowment for the Humanities to begin curricular work to develop digital dimensions for our Health, Humanities, and Society curriculum. And we're particularly excited by this project, especially at Northeastern, where we imagine it as building Northeastern's strengths in digital humanities and health humanities. And I have a long piece, or semi-long, that I will not share with you about why this work is so important right now, because I have a feeling that our speaker is going to do a really eloquent job of that herself. This work is, after all, really grounded in Kirsten Ostherr's scholarship, and it was really foundational to our own imagining of what the humanities might offer the future of health and healthcare. So we're just so thrilled to have her. So without further ado, I'm going to introduce our speaker today. I'm delighted to have the opportunity for us all to be in conversation with Kirsten Ostherr. Ostherr is the Gladys Lewis Fox Professor of English at Rice University in Houston, Texas, where she's a media scholar, health researcher, and technology analyst. Her research on trust and privacy in digital health ecosystems has been featured in Slate, The Washington Post, Big Data and Society, and Catalyst, and she recently published on medical humanities and artificial intelligence in the Journal of Medical Humanities. And also she has published some on COVID, which was featured in Inside Higher Ed, and also in a forum that Priscilla Wald and I co-edited for American Literature. She's currently leading a multidisciplinary project called Translational Humanities for Public Health that will identify humanities-based and inspired responses to the COVID-19 pandemic to document and help others build upon these creative efforts. She is the author of Medical Visions, Producing the Patient Through Film, Technology and Imaging Television and Imaging Technologies from Oxford, and Cinematic Prophylaxis, Globalization and Contagion in the Discourse of World Health from Duke. She's editor of Applied Media Studies from Rutledge and co-editor of Science Animation, a special issue of the journal Discourse. And she's currently writing a book called Quantified Health, Learning from Patient Stories in the Age of Big Data. With the support of a Mellon New Directions Fellowship, she completed a Master of Public Health degree at UT Houston School of Public Health. Her MPH research focused on the use of information and communication technologies in end-of-life care. She's the founder of the Medical Humanities Program. She has clearly a long list of accolades, so I'm trying to give you a taste of them. She's the founder and director of the Medical Humanities Program, which was founded in 2016, and the Medical Futures Lab at Rice. The Medical Futures Lab is a collaborative center that brings together faculty from Rice, Baylor, and UT Health to reimagine medicine at the intersection of humanity and technology. Through the Medical Futures Lab, she and her team teach a series of digital medical humanities courses that train students to solve real-world healthcare problems through collaborative participatory design practices. And she has a number of ongoing projects. She has projects on trust and privacy in digital health and AI, simulation as a mediator between human and technological forms of medical expertise, and human-centered design as a technique for patient collaboration in health technology and development. She co-created Medicine in the Digital Age on edX, which is an open online course that's reached tens of thousands of global learners. And she's spoken at audiences at the White House, at the WHO, at the National Library of Medicine, TEDx, and a number of other places worldwide. So we are just so delighted to have her. And again, one of the things that's so fantastic about this for us is that we've had a whole year of trying to think about digital health humanities, especially curricularly, but also in terms of its potential as a field, and much of that has been inspired by her work. So without further ado, I will leave it to you to start. Thank you so much.
Thank you so much. That was a very lovely introduction. I really appreciate that. Let me go ahead and share my screen to get started. Okay, and let's see, can you see my screen all right?
Yes.
Excellent. Okay, great. So let's get started here. So again, thank you so much for the lovely introduction and the invitation to speak with you today. I'm really delighted to be joining you, and I'm really happy to be contributing to this effort that you have ongoing at Northeastern. So I think probably everyone who is on this Zoom listening to this lecture today is all too aware of how digitally intermediated our lives have become during this pandemic. You know, as you probably know, the very same Zoomification that we've been experiencing in higher ed has of course taken place in healthcare too, literally from clinicians using Zoom or Zoom competitors for telehealth visits to virtual rounds in the hospital and other variations on the theme. So I want to talk about the implications of this shift today, starting with a few comments on the terms data and digital health. So the outline of my talk is that I'm going to have a little prologue about data and digital health. Then I'm going to talk about the technological and data-centered responses to the pandemic, especially in the early days, that set a certain tone that I think has serious implications. I'll discuss digital contact tracing as kind of a case study of this. And then I'll talk a little bit about translational humanities methods that we might consider as an alternative. So this is the prologue. The rise of telehealth was already underway, well underway before the pandemic really launched the practice into high gear. And the pandemic did so partly because virtual visits began receiving Medicare reimbursements, but also, of course, patients wanted to stay out of hospitals, and hospitals needed to protect their workforce from exposure and forced quarantine. So in this context, the digital interface was, you could think of it as a protective extender of human capabilities. But quickly then also AI chatbots began being used to triage patients whose needs were not acute, so that amidst the spiking demand for consults, though only those patients who most needed to speak with a live person could do so, and the others were vectored to a chatbot who would answer their needs. And I mean, it's important to note that these practices did serve a real need in the early days of the pandemic, but they also opened an opportunity that digital health startups and big technology companies had long been waiting for, which is the opportunity to access vast quantities of patient data as a condition of providing digital health services. This rapid shift was facilitated in part by the Centers for Medicare Services enforcement discretion rule, which allowed providers to use many consumer-grade video chat tools, as are highlighted in this excerpted text that I pulled here, such as Apple FaceTime, Facebook Messenger, video chat, Google Hangouts, Zoom, or Skype, to provide telehealth services without risk of being penalized for non-compliance with HIPAA rules, because these services were not as privacy compliant as they would be required to be under normal circumstances. You can note that there were certain services that were ruled out as too non-privacy compliant, such as Facebook Live, Twitch, and TikTok. But nonetheless, you can see also that the possibility of using consumer-grade video chat tools was enabled through this enforcement discretion. So this is what that ended up looking like. This is from a piece about how one hospital switched to telehealth. And you can see in this image here, you know, it's just kind of a rig for holding an iPad that could be that's basically like usually used for IVs that could be just rolled around in the hospital to have what they call tele-ICU and video consults. And you can see in the graphs over here how quickly the demand for telehealth rose, paralleling, of course, the skyrocketing case numbers in the United States. The US approach was modeled on how Chinese companies had quickly turned to telemedicine in December of 2019 by mobilizing existing technology companies. Chinese telemedicine services such as Ali Health, which is part of Alibaba, which is a huge, it's kind of like the Amazon of China. JD Health and WeDoctor, which is backed by Tencent, another massive technology conglomerate. They all quickly launched coronavirus clinics to triage and treat patients across the country. And you can see that the way that technology companies leapt into this void in the United States too, that the business model was rapidly shifting. But from the patient side of things, in order to accept telehealth as an equivalent substitute for an in-person visit, we have to be willing to accept the digitization and datafication of care. There's a huge push in the computational sciences and in engineering, as well as in the business of healthcare, to identify digital proxies for bodily signals. And these are sometimes called digital biomarkers. But what is lost in these trade-offs, not only on an individual level, but more importantly, in our broader conception of health and care? My talk today will examine some of the consequences of the datafication of human health in the context of the pandemic. And this is just a figure from a recent piece that was published in Nature Biomedical Engineering that is asserting that smartwatches can detect COVID-19 in pre-symptomatic people just from smartwatch data. So let me just take a moment to define what I mean by datafication. This term was first used in 2013 to mean the effect of individual action sensory data and other real world measurements, creating a digital image of our reality. It was expanded to be understood as a process of rendering into data aspects of the world not previously quantified. And then Van Dyke and Pohl brought this into the healthcare context to discuss the way that in the context of datafication, every aspect of one's physical or mental well-being is translated into data. Vital signs, objective measurements, subjective experiences, medicine intake, personal information, test results, etc., and transformed into new kinds of value. And that last part is really key. So I'm going to argue today that datafication facilitates data-driven healthcare and enables the construction of a data-driven pandemic, data-driven in quotes. In this paradigm, data functions as the privileged form of evidence for medical knowledge creation, while for the health humanities, that role has most consistently been filled by narrative. In the presumed data narrative dichotomy, several important attributes emerge, as you see here in the comparison that I've put on this slide. So you can kind of look at the different associations that I've lined up under data and narrative here. In this formulation, data is a building block of science, while narrative is not. Thus, the patient's story may hold important clues to the history and likely trajectory of a disease, but it is rarely incorporated into the medical record beyond minimal fragments or into clinical trials. Of course, a major contribution of health humanities scholarship has been the critique of the data narrative dichotomy. As health and medical humanities scholars and others have demonstrated, commonalities between data and narrative include how they are structured by contextual specificity and social construction, as well as the role of interpretation and making both forms of evidence meaningful, while illuminating how quantitative data are themselves the products of situated values and priorities in scientific research and technology development. Critiques of this dichotomy also highlight how data function in medical and health contexts to validate normative perspectives and concerns and marginalize or pathologize others. So I want to build on that prologue in the rest of my talk, where I will discuss the consequences of framing the pandemic as data-driven, concluding with some ideas about some alternative approaches. And I want to start by talking about how the immediate response to COVID as a technological and data problem produced specific results that have distorted our understanding of the crisis itself, as well as limiting our framing of potential effective interventions. So a starting question is this: how have technologically mediated data shaped the visualization of the pandemic? A couple of brief thoughts about this. I want to touch on ventilator shortages. In the early days of the pandemic, there was a lot of effort put into trying to make up for what was expected to be a shortfall in the availability of ventilators, which were seen as the most critical and essential intervention into the pandemic to prevent the loss of life. We had a team at Rice here in our bioengineering department that developed a kind of a model for a sort of do-it-yourself ventilator that could be made cheaply with readily accessible components. And other companies that usually make other things like car parts shifted to making ventilators. There was a lot of virus imagery that we saw early in the early days of the pandemic too, that reinforced the technological frame, the idea that we can only see and understand the virus and the outbreak through a mode of visualization that encourages us to align our understanding with technological explanations and interventions. The image of the virus, which we cannot see with our naked eye, and it doesn't really help us avoid infection. This was one of the, I would say, preeminent products of the technological framing of the pandemic. I'm sure that all of you have seen this dashboard before. This is the Johns Hopkins coronavirus dashboard. This is a screenshot from back in October of last year. The map would look different today. And this is, in my view, kind of a paradigmatic example of what the data-driven pandemic looks like. This is a version of it from where I live in Harris County, Houston, Texas, which is built on the same open source platform. So you can see that aesthetically, these two images look quite similar. And this platform has been widely used to create data dashboards around COVID. And that's part of what I want to talk about today. So when we look at COVID through these lenses, what do we see and what remains invisible? So one thing that we see when we think about just the ventilator example is that it became clear fairly early on that, first of all, ventilators themselves are not very useful if you don't have skilled healthcare professionals to operate them. And second, that ventilators themselves actually often caused more harm than good with patients, and that the death rate in patients that were put on ventilators was much higher than for those who were not. Of course, for some patients, it was absolutely life-saving and remains that. I'm not arguing against the use of ventilators. I'm just trying to make the point that framing the most important response through the technological lens has certain repercussions, and this is one of them. But another variation on this is the question of what it means when we think of this as a data-driven pandemic, as a pandemic that we see as a data visualization. And part of that discussion has to center around missing data. So if you don't have adequate testing, of course, you can't have adequate data to represent the true incidence of the disease, right? And there's been reporting on how access to testing has followed the same lines of racial disparities that we've seen throughout this pandemic. So that, of course, skews the results of the data. I wanted to just show you this image because I appreciate the lengthy caveats that this is from the UT School of Public Health that they put on their website to try to explain and contextualize the meaning of the data that they present in their dashboard. The point that they make, you don't need to be able to read all of this, is just that it's very hard to get clean and complete data in this context, right? And so one of the things this leads to, I'm arguing, is incomplete narratives. We see this, of course, also going back to April of last year, Ibram X. Kendi wrote in The Atlantic about how it seems that there is a greater impact of the pandemic on people of color. And he said it seems that because at the time, racial and ethnic data were not being systematically collected. In fact, they still are not. So he had that impression, but could not point in a kind of conclusive way to data that would show that. It's that information is lacking in many of the CDC case reports. So something that we can conclude just for this part of the talk is that data are always missing, messy, and provisional. And one of the key points that I want to emphasize in response to this is that COVID-19 makes it very clear that health humanities must engage with data as a central site of ambiguity and uncertainty in healthcare. This is certainly true in the context of the pandemic, but I would argue that it's true much more broadly when we think about the way that healthcare as a whole is moving in this direction of being data-driven. To follow on that, I want to argue that the way that we see the pandemic as a result of this data-driven frame results in a kind of techno-scientific mediation that produces spectacles of data-driven visualization, like the Hopkins dashboard, that erase human narratives of suffering. So that's going to be the main focus for the rest of my talk. Okay, so this leads us to digital contact tracing. So given that I've been describing the pandemic as both data-driven and also at the same time data poor, I want to ask the question, what counts as evidence in this context? And what do the data visualizations that that are so ubiquitous, what do they obscure? So a little bit about contact tracing. It is, I'm sure you all know, a decades-old disease control method that's been used in public health to try to stop the spread of infectious diseases by identifying, testing, and isolating people who are sick. Right? This is again, the Harris County Public Health Department's website. And of course, this was something that got a lot of emphasis at the beginning of the pandemic in the United States. It seems that there's not as much emphasis on it anymore because we have failed so completely to actually undertake contact tracing on the level that it needs to be pursued on in order to actually have an effect. But I want to point out some of the aspects of contact tracing that the local public health department here emphasized in a contact tracing myths poster that they included on their website. And what I specifically want to emphasize is the emotional aspects of the questions that are addressed on this poster. So some of the myths that they address, this question: can I get deported if I cooperate with a contact tracer? Will I lose custody of my children? Do I have to pay for contact tracing? Can I get put in jail or under house arrest? And will I be tracked through my phone if I work with a contact tracer? So all of this shapes, in my view, how we need to think about the data that we may gather through undertakings such as this one. So we have missing data, we have incomplete data, we have provisional data, and we also have this larger context, which is surrounding the capture of data in the first place, which is people's questions about trust and the reaction that they may have to the efforts of contact tracing. And now we can extend this to getting vaccinated under the same kind of rubric, all of which shapes the numbers that we actually get in our data sets, but which are not visible in them. Just a brief mention of the longer context for contact tracing, which has been primarily associated with sexually transmitted diseases in the United States. And especially, these are two old World War II era posters referring to that in relation to syphilis, but of course also contact tracing really became part of the public discourse around HIV/AIDS. And in that era, there was a lot of discussion about the right to confidentiality of the infected person, the right of their partners to be informed about exposure. And so there was a lot of recognition that there were trust issues that were associated with the practice of contact tracing that had to be addressed upfront in order for the practice to be effective in any way. Now, in the current context, on the one hand, we have these issues about trust and human interactions, but there has been a huge push to do digital contact tracing, as you probably know. And part of the argument is that the sheer scale of the pandemic is such that it would be impossible for there to be enough human contact tracers to actually do all of this work. Whether or not you actually accept that assertion, that led to the move to pursue technological contact tracing through digital contact tracing apps, which basically work a couple of different ways, or they would if they were widely embraced, that people would have to download an app and enter location and symptom information, or enable an app to gather all that information automatically. In addition to often location finding technology, which would enable two different phones to talk to each other when two people are in close proximity, one of whom has been exposed. There was some discussion early in the pandemic about whether it's possible to have privacy protecting digital contact tracing apps. And this is a study that came out in 2020, I think around May or June, that was a study of digital contact tracing in South Korea, which found simply that using the log of data that the app gathered on an individual, it was very easy to re-identify the user of the app. So again, and this has been shown in many cases in studies of big data that claims of anonymity or privacy protection usually do not bear out. Okay, so what are the consequences of this then? Well, again, in South Korea, the contact tracing apps were used in tandem with things like surveillance camera footage, smartphone location data, credit card purchases, etc. And this produced a very strong sense of surveillance, which many people strongly objected to. But the other thing it did was it created a very strong sense of fear and worry about being identified as a person who might be a source of spread of the virus. So this goes back to what I was saying earlier about the role of emotions, affect, in the response to data collection and how that shapes and produces gaps in what we consider to be the representation of the pandemic. We see this also in examples from other disease outbreaks that public health officials in the context of COVID have looked to see, well, like how did they do contact tracing in Ebola outbreaks, for example? Are there things we can learn from that? And one of the things that we can learn is that these issues of fear, shame, and stigma and mistrust are very prevalent in many disease outbreaks, regardless of how different the diseases themselves may be. So a study of digital contact tracing and the ethical issues surrounding it that came out last May, that was conducted at Johns Hopkins, found that there were some real benefits to manual in-person human contact tracing as compared to digital contact tracing, including that those contact tracers could then clarify misconceptions, address worries, express sympathy, and other important affects, which a digital app could not do. So of course, this relates very much to racial and other health disparities in the context of the pandemic. When we think about, again, the gaps in the data and who will or will not participate in these kinds of data collection efforts. So Caitlin Esmond, who was part of the group who wrote that Johns Hopkins report, wrote a piece in Vox where she talked about the importance of officials, health authorities regaining the trust of Black communities and how that is really a necessary precursor to any kind of digital contact tracing actually being functional in the real world that we live in today. There are many examples of this. In California, one of Google's subsidiaries, Verily, launched a big digital contact tracing program, which several large counties, San Francisco and Alameda County, participated in, but stopped participating in fairly early on when they saw that the program was actually, though it was supposed to boost testing in low-income Black and Latino neighborhoods, it was actually doing the opposite and benefiting higher income residents in other communities. So a researcher, Ali Al-Khatib, commented on this and the consequences of these gaps in who we are actually identifying when we are producing data about the pandemic, saying that we should care that the gaps in our knowledge will be consequential and non-random, specifically because these gaps will sabotage our efforts to understand what's actually going on in the world and will undermine our response. So I think this is a really critical point here, which is that the response to the pandemic is very much dependent on the data representation that I've been talking about and that we're all very familiar with from the past year. And so if that data representation has really fundamental gaps in it, then any response that's based on that also is going to be fundamentally flawed. Another example of this is that in the early months of the pandemic, Native Americans were not actually counted as Native Americans. They were counted as others in the case report forms, which, as one member of a tribe in Seattle commented, means that if you eliminate us in the data, we don't exist. We don't exist for the allocation of resources. So, and even the people who create these kinds of tools are unsure themselves of how to design them in a way that doesn't reproduce the exploitative or exclusionary dynamics that we've seen in so many digital health technologies and that I've been enumerating for you today. So Ramesh Raskar, who's at the MIT Media Lab, commented, how do you create a solution that doesn't end up becoming a tool of the surveillance state? That's the biggest challenge for us. And that's a challenge kind of across the board, but it's a particular kind of challenge in the healthcare context. So we can take from all of this that there's a great deal of shame, fear, stigma, and mistrust that surround contact tracing, digital contact tracing efforts that surround the production of data about the pandemic. And that at the same time, the ability to express sympathy and other important affects is really critical to the pandemic response. And in my view, one thing that this leads to is the need for data tracking and technology development to have more humanist intervention, primarily because as the report noted, digital contact tracing apps are not good at expressing sympathy and other important affects. And further, if we go back to the data narrative dichotomy that I presented earlier in this talk, we need clearly to bring those two realms back together in order to fill out the gaps that are missing in this data representation of the pandemic. So the question is, how is that possible technologically, and or how to intervene in the technological data-driven framing of the pandemic such that those narratives can come back into play. So that brings me to the last part of this talk, new methods, translational humanities. So I want to just return to my core argument that I mentioned earlier to you, that technoscientific mediation produces spectacles of data-driven visualization that erase human narratives of suffering. So the tension between the data-driven visualizations and the human narratives of suffering, of which we have all heard throughout the past year and have experienced directly, yet are not present when we think of the pandemic through the representations that I showed you earlier, the data models. And so for this reason, I think we need translational health humanities data analytics, if you want to call it that, to foster social justice and health equity. And I want to show you some examples of that that I would consider to be translational humanities interventions. Many of the examples I'm going to show you are sort of data oriented, though they extend outwards. And so, for example, this project, which unfortunately probably a lot of people have heard of in the past couple of weeks because of the attacks on Asian Americans in this country. But this site, Stop AAPI Hate, it was created by a professor of Asian American Studies at San Francisco State University, Russell Jung, back in February of 2020. And he created it just to document all of the xenophobic attacks that were occurring amidst all of the xenophobic language about the source of the virus, which I'm sure that you all remember, unfortunately. So it started off as just basically a database, like there was a form that you could submit in many different languages and describe what had happened to you, to someone you knew. And he wanted to do this to make clear what was actually happening, which we would have known already from the history of medicine, from the history of public health. We know that it's rife with that these kinds of global outbreaks are rife with xenophobia and with racism. But he wanted to document it in the current moment, and his efforts since then have really yielded the results I think that he was hoping for, which is that in February of this year, the California legislature enacted a law that included over $1 million of funding specifically to support this project and their website, their analysis, and their research. So to me, that is a really important way of bringing together narratives and data to make a translational humanities intervention. So that's one example. Now, this one isn't data-driven, but it is a translational humanities approach that I just wanted to share with you. Early in the pandemic, the UN put out a global call to creatives to help stop the spread of COVID. And what they were doing was specifically acknowledging that health communication, like data, is contextual, is culturally specific. It does not make sense if it is not produced in a way that relates to the people it is oriented to. And so they sought out artists all over the world to create images that could be used in public health communications. And here are just a few of them. There's one from Brazil, one from Belgium, one from Panama. So I think what I like about these is that to me, they're an example, again, of the kind of aesthetic wrapping of the data about the global dimensions of the pandemic in the context of visual forms of representation that are unique to and resonate with people in local specific communities, situated communities. But I was mentioning that we know from the history of pandemics to expect xenophobia. And I wrote about this in a piece in the Washington Post that's really about the history of public health films, but using them as a way to explain and sort of anticipate what was probably going to come, and also to try to guide public health communications to not fall into the trap of racist contagion narratives. To me, this is also a translational project. Similarly, there was a piece in Scientific American that talked about the way that we can look at the historical accounts of the 1918 pandemic to identify what were the most effective interventions, in fact. And this piece that was posted about that suggested social distancing, good communication, and international cooperation, all of which I just want to emphasize, of course, are not technological interventions, right? These are actually simple and easy for the most part to accomplish, or at least to encourage people to accomplish, much simpler than producing ventilators, for example. Similarly, I wanted to mention the Global Health Histories series that is sponsored by the WHO and is based at York University, where for years they have been presenting seminars that explain the history of health in the past 60 years, but in ways that help the current public health community shape their responses to current crises and challenges. Now, getting back to kind of the data-oriented responses to the pandemic that I see as really important translational interventions. There was a piece that was posted about prisons and about the way that the America's COVID-19 hotspots, including prisons, factory farms, and nursing homes, really show that the data around the pandemic, if we look at them in a different way, can illuminate our societal values in such a way that it helps reshape how we think about where the necessary interventions for the pandemic are. A couple of additional examples of this are from the Urban Systems Lab at the New School for Social Research and at the UCLA COVID Behind Bars data project, both of which are trying to build on sort of the insight that I was just talking about in the previous slide to analyze and understand and also just actually capture data about either COVID incidents inside of prisons, which is still very unevenly available, and also to understand the relationship between, say, climate and social vulnerability and COVID vulnerability, again, which are not the dominant frames for how we think about data in the pandemic. So I have found the use of D'Ignacio and Klein. They have a recent book called Data Feminism, and they published a piece sort of translating some of that specifically about COVID in big data in society recently. And they talked about emotion, again, going back to these questions of trust and of whether or not people even appear in data sets around the pandemic. They argued that valuing emotion as a part of a data science project grounds us back in the world and among the bodies from which data are derived. They argue that this is particularly important if we aspire to undertake responsible data visualization in a health crisis that is having disproportionate impact on specific populations. So I appreciate very much their emphasis on thinking about data as something that is connected to bodies, that is embodied, and that also, therefore, especially in the context of crisis and of vulnerable communities, has an affective dimension that is actually not noise that needs to be stripped out of a data set, but rather can inform and help us better interpret what the data actually mean. So I think a project that is a really excellent example of this, if you compare, again, so here's the Hopkins data visualization, and let me just say as a sidebar, it's not, I don't think this is sort of a bad thing that this exists at all. I think it's been very valuable to policymakers, to regular people around the world. However, as the dominant lens for how we think about the pandemic and the scale of it, that's where I think the problem comes in. So if you think about that as a techno-mediated data visualization, you can contrast that then to this project called COVID Black, which is run by Kim Gallen, who is a professor at Purdue University. And that project, as is described here, is one that is meant to remember Black lives and restore their humanity. So she has this project called Homegoing here, where these are two screenshots from it, where they've basically been constructing a huge database of African-American people who have died of COVID. And so that's the database, but they've pulled this from newspapers and other kinds of maybe social media accounts, from any resource they can find. And they have a long panel of images that you can just scroll down, the names alongside of that. And then these these sort of oblong images, they're actually moving. They're going upward on the screen continuously as you look at the site. It's a really beautiful site, and I encourage you to look at it. And then if you click on either a name or a photograph, you get this pop-up with a little biography of the person who it's about, as well as a link to whatever the original source was of an official obituary or something else in some other form of media. And Dr. Gallen has talked about this as a way of restoring narrative to data in the context of the pandemic. And in my view, this is an excellent example of that. You can see the kind of data orientation here in another project that's called Data for Black Lives, which is trying to do a similar thing, but highlights specifically the numbers in the context of the Black community. So they're just capturing data from all over the world, similarly to present an understanding of the impact of the pandemic. And they make an important point on their site about how the context of big data in general and the tools that we are using to understand the data-driven world that we're living in have tremendous potential to empower communities of color, but that's not how they've usually been used. So they are together trying to take ownership of data about their own communities to represent it in ways that will be more meaningful and respectful and human in relation to their communities. So, and this is really critical work to do in the current context, because as I mentioned earlier, the data on race and ethnicity are still really lagging. So this is a screenshot from the CDC from just a couple of days ago, and this shows risk of infection, hospitalization, and death by race and ethnicity. And they, down here, they note the references are on the back. And in their first citation, they note here that these calculations use only the 53% of CDC case reports that have race and ethnicity data available. So that is missing data to this day. So we're missing about half of all of the racial and ethnic data on incidence of COVID across the United States. So in closing, I just want to remind everyone, I think probably everyone in this in the audience knows this, but of course, narrative has long been a central preoccupation of health humanities. I mentioned this at the beginning when I talked about the false dichotomy. And we were already grappling with the relationship between narrative and data before the pandemic in trying to bring together the insights and practices of narrative medicine on the one hand, with the growth of patient narratives being communicated online, for example, which produces them as huge data sets that then become vulnerable to mining, but that are also the sources upon which AI systems like the bot that I mentioned earlier and others are being built upon. So this was already a central site in need of much investigation. And I think the pandemic has shown that even more so. So Sarah mentioned in her introduction that I was working on a project called Translational Humanities for Public Health. And what we're doing in that project is trying to gather, many of the projects that I just described to you are part of that database. We have a survey that we've sent out to hundreds of people. We've got over 260 responses so far. And we're soon going to launch this as a public database that showcases all of the different ways that people around the world are using humanities methods and insights to intervene in the pandemic and to help people on using the methods and tools and practices of the humanities to intervene in ways that restore the kind of narrative integrity and the human experience that we are having to balance out what otherwise does not look like or feel like a very human representation of the pandemic. So I will end by just leaving the QR code for our survey on the screen, so that if any of you are working on any kind of COVID project and you would like to be part of the database, I'd love to have you scan this and fill in a survey. And I thank you all very much. Okay, and I'm going to stop the share. Thank you.
Fantastic. It was so great, and yes, and I'm just so delighted. I've been following some of the work that you've been doing about the pandemic, and it's just so great to see so much of it come together. And I love especially your articulation of the relationship between data and narrative. I think in terms of people, we can do this however you'd like in terms of questions. I think what I'll do here is I will ask a question to begin with as people are kind of gathering their thoughts. And then yeah, and then you can do a couple of things. You can, raise your hand. You can, and Gabby has very helpfully given some directions about how to the different ways of participating in the Q&A. But one of the nice things about this, the reason why we wanted this not to be a webinar, but actually a Zoom meeting, is so that people can ask questions directly if they'd like. So my question comes out of actually some things that I've been thinking about, which I feel like is sometimes a dangerous way of asking a question. But one of the things that I really loved about the way that you were thinking through the kinds, both the, what data makes possible, and also the ways in which data representation has kind of obscured certain dimensions of the pandemic. I mean, I think you did such a beautiful job of talking, especially about the spatial dimensions of that, about the technical dimensions, about the demographic dimensions. One thing that I've been thinking about, and I'm just wondering if you have thoughts about this, is about the temporal dimensions of the pandemic as well. And I'm asking the question really in whatever way you want to answer it. But one thing that I have been interested in part, is this historian Scott Knowles has this concept of slow disaster that I think is really quite powerful and useful for thinking about what the concept of disaster makes possible for us, and also the ways in which it really obscures a lot of both the causes and effects of disaster events. And so for him, right, the temporality of disaster is a huge problem, because it asks us to focus on the acute, as opposed to thinking about a much longer time period. For example, this makes climate change very difficult to track. But another thing that actually I've been thinking about with some of the people on this call has to do also with the sort of temporal, the encouragement of thinking about things temporally, that has to do with the slide that you showed that tracks cases, hospitalization, and death. And I'm thinking about this sort of in two ways. Like, okay, you can't actually track cases until people have already been infected and already sick, right? And so there's been so much difficulty around telling people that they can be infected before they can be tested. The lag in testing really means that those numbers are always at least a week delayed. And there are, I think, a lot of other temporal dimensions to the pandemic. So I was wondering if that's been something that it was a long question that was also kind of a comment, but I'm wondering if you have any additional thoughts.
Yes, I mean, this is a really fascinating and challenging aspect of the pandemic. For one thing, so the figure that I showed from that recent Nature piece about using smartwatches to identify COVID in people before they're even symptomatic, right? It's really fascinating to me, not only because I've long been interested in and written about digital biomarkers and their strange sort of form of existence, but also because, in the history of public health and the history of public health films, which I've studied and written about a lot in the past, there's always this preoccupation about visualizing the invisible. Right. So like, if only we could see COVID, it would be so easy to contain it. It would be so easy to avoid getting sick. And that has led to all of these attempts to visualize it that usually end up pathologizing people who are seen as the other, who is the source of the contamination. Right. And so that's where we get all of this xenophobia, these anti-Asian attacks that are premised on that same exact form of xenophobia, which we see over and over and over again in all of these cases. So there is a way in which the desire to be able to see something before we can see it, and because when we can see it, it temporally occurs much later, right? When you actually have symptoms. So there's that time span where we don't know that there's nothing visible and we can't see. And so, that has led to efforts to detect the presence of infection based on something that is, like your heart rate or your sleep habits or your activity levels, things like that. And, in that particular piece, they believe that they could do it, but that speaks to just a larger problem that is endemic to all of these data visualizations, which is not just the missing data, the lag in data. I mean, in our local reporting, it regularly happens that there are spikes in the data visualization due to the fact that a whole bunch of cases that were actually tested 2 weeks ago just finally came through, right? And so, they try to sort of smooth the data so that it is still an accurate representation. But what this means is that the representation of the pandemic is constantly changing. We are still rewriting how it has happened from over this past year, as we will for a long time, because we're learning that many misdiagnoses actually probably were present in the United States and other places, and so the numbers are skewed in that way. So there's a way in which the temporality of the representation it's constantly lagging also. But on top of that, I think there's a different temporality, which is that of grief and pain and suffering, which isn't visible in the data visualizations, but has affected so many people around the world. And many people who have written about grief have described it in temporal terms, right? In the way that time seems to stop, or it slows down, or things just don't align in the way that they might make sense in terms of temporality under other circumstances. So there too, I think that the tension between understanding the pandemic through data, through big data, and understanding it through narratives also exposes the different temporalities of those two things.
Fantastic. And I see Jay Brook has his hand up, and as somebody who has spent a lot of time living with this up close, I'm really curious to hear what you think about it. And then afterwards, there's a question from Molly Nebbiolo. So yeah, Jay.
Hey, Kirsten. How are you?
Thanks for coming.
Hey. So this is, as always, fantastic. I mean, I think there are a couple of pressure points that I'd probably push back on in your talk, not because I necessarily disagree, but I think they just need to be unpacked a little bit more, which you probably unpack in your book or whatever, as you move forward. But there's one central thing that I think I want to sort of throw out there. And that just seems to be that you're trying to sort of make an argument for the role that we need to sort of be incorporating narrative as sort of a numbing effect of data. Like, I don't think we're erasing data. I think there was an outright distrust of data from the outset. So it became emotional from the get-go. It was never sort of objective and neutral, or was never thought to be objective and neutral. And even the most neutral, quote unquote, data is always interpreted. Mm-hmm. Right. So it's not always objective. Like, there's always a subjectivity to how data is used. It's like the data, and then there's how we use the data. Mm-hmm. And so, thinking apart from the pandemic, what I think is just so interesting is that, in medicine, where we're trying to be so evidence-based, right? We are always taking the evidence and applying it to the narrative. I think it's vice versa. I don't think you need to find the narrative from the data. I think we're always using that narrative. Always comes first, whether we recognize it or not. Mm-hmm. And if the data doesn't fit, if the evidence doesn't fit to this particular patient, it's amazing, like what practice patterns clinicians have, mm-hmm. and they know the data doesn't show it, and they go, it doesn't make sense. It's not illogical. This is my practice pattern. Yeah. So I think there's a general foundational disconnect, mm-hmm. that is there, and then you throw in the whole charged emotions of the pandemic, which I think, of course, changes everything. But I got to tell you, I think it's not the the fact that data is erasing a narrative. Is the fact that I think we're all numb from the data.
Mhm.
I see it every day. I mean, I saw it yesterday, and we're numb. Like, I think people are numb. I think at one point does like data like just washes over. Like you once you're in the shower for a minute, or you're in the shower for 10 minutes, you're still the same degree of wet. And so this is not so I think narrative is absolutely essential, not to find ways to sort of personalize the data, to actually to put emotion back into the data, to sort of rehumanize the data and sort of pull it back. And because I think there has to be a thawing out process where we all begin to feel again. And I think that sort of touches upon a little bit of what Sari's question about the temporality and like what happens over time when the disasters sort of continue onward. But as always, I loved listening to you. It was so much fun. It was just, thank you.
Thank you. No, that's a great comment. I mean, I guess what I would say, a couple of things. So I think there's a difference between what you're describing in like a clinical encounter between a doctor and a patient, say, and what happens on the scale of public health and policy. And I think that in those different domains, the default to the data-driven representation is strong. And I do think also in medicine as a whole, I would love it if it were the case that narrative was really foregrounded and valued in the way that you're describing everywhere. But what I observe is that, especially in the impulse to bring in technologies that are based on interpretation of data through algorithms, right? Like AI and like risk sort of management software and those kinds of things that cut out the human interaction in part of the exchange. Those interventions make it impossible for the scenario that you described to fully play out. So it's not the case that they're completely displacing clinicians by any means, but as a kind of overlay on clinical encounters as a whole, like at a sort of system level, I think that shift then has certain effects that skew to the data-driven framework simply because that is what they're built on. They're trying to figure out ways to incorporate unstructured data like text and narratives and that kind of thing. But the way that they're doing it is in a very decontextualizing kind of way. So I think that there are ways in which both of these things are sort of coexisting in clinical settings, but also in the larger world as a whole. So I hope that the scenario that you describe sort of wins out and is what we experience more so than the alternative. But I've been watching the kind of rise of, AI-driven systems in healthcare, and they're not friendly to messy narratives or to emotion or to kind of the sort of ambiguity in human interaction. Does that make sense?
The question in some of the work that we've done with sort of data visualization, sort of in some big studies we've done on, arts in medicine, like the central question that we always came up with was, the power of data visualization, but also the question of who is the data for?
Yeah, right.
Right, like why, like who is going to be using, like who, like going back to your design aspect of all your work, right? It's like, who's going to be using this data? How are they going to be able to use this data? How is it going to resonate with them? Because sometimes I feel like the data is, we don't necessarily think about like who understands this data? How does it actually connect? Does it engage? Can we demonstrate data in a very beautiful and resonant way that works for certain people, but not maybe the people that we really need to address and we really need to be connect with?
Mhm. Yeah, yeah, yeah. I think that's a really key question.
So I think the hands are Molly Nebbiolo, who's a graduate student at Northeastern, followed by Ashley Brown, who's an undergraduate, and then Karen Thornburg.
Excellent.
Hi, can you hear me okay?
Mhm.
Okay, because my internet's kind of spotty. That's why I put my question in the chat. I was just generally interested in hearing your thoughts on kind of how much of this is very unique to what's happening with COVID-19 and how much of it is maybe like how much have we learned from SARS and Ebola with those happening in the 21st century and those being kind of other instances where we have a lot of like, you know, technology, data collection and things like that. Have we learned anything from those two kind of more recent instances that we see any sort of result with COVID-19, or is this kind of a longer, more perpetual, you know, set of issues that you've noticed?
Yes. Yeah. So I think that in the Southeast Asian countries that really dealt with SARS directly in a much bigger way than we did in the U.S. They learned some things. Like they learned how to have it be socially normative to wear masks, and that has been very helpful actually. And it's kind of not politicized in the same way there that it is here, and that doesn't really speak to the data narrative question, but I think that is one learning that has been really critical. But you know, a different one from Ebola has been the necessity of really taking a culturally grounded approach to contact tracing and every other kind of intervention, because anthropologists and others were on the ground in recent Ebola outbreaks and saw that, for example, technological interventions like using digital contact tracing apps completely failed because of the ways that people use phones there. Like several people might share a phone. So right there, the whole model falls apart, right? So who was exposed and when and where and who had the phone at that time. And so you can see how like the being on the ground in places where different kinds of outbreaks have occurred really exposes some of the flaws in the sort of technological model. The larger question about the data narrative tension, I think very much predates COVID. It's been exacerbated in the context of COVID and made more visible in this context because also at the same time, I mean, one of the things I didn't really talk about that much is the really strong impulse to tell stories that you're seeing everywhere in hospitals. I mean, I've heard, you know, the CEOs and the CMOs of hospitals saying like, wow, we really need to create a space for our workforce to like process this, to like tell their stories. And like people who do not usually go around talking about the importance of narrative, you know, are seeing that actually people really need to tell their stories. And it's not sort of an extra like thing that they can choose to do if there's time. It's like actually central to the kind of human survival of this whole thing. So I think that there's both a newfound appreciation for what narratives do and why they are necessary that I actually find hopeful, despite the kind of context that they're emerging in. But at the same time, the push to telehealth and you know, like the chatbots and the AI systems that I was mentioning at the beginning, that's also happening concurrently, and I see that as very much pushing in the opposite direction and in ways that are concerning to me. Yeah.
Fantastic. So Ashley, then Karen, then Chris.
Hello, yeah, I'm Ashley, and actually it's a very interesting. You mentioned that like the data feminism or feminist data. I forget the order, but I actually just read 2 chapters of that today.
Oh, really? That's cool.
So I was like, oh,
Great.
so I guess it's kind of on my mind, kind of particularly talking about like the integration of emotions with data.
Mhm.
Because yeah, I was reading it for a course, and our discussions, a lot of the people in there are like computer scientists, and they were like, it was just, they had a very visceral response to people talking about emotions and data. And I just, yeah, so it was very interesting. But I guess my question related to that is, how do you communicate these kind of things to people who aren't as like humanistically trained, and they're thinking that like, or I guess, how do you convince them that emotions are helpful for data? Because since like data scientists are often like, people putting it together aren't humanists, so how do we get them prepared? I guess if
Yeah,
you have thoughts.
that's a really great question. In some ways, not that differently than how I presented it today. In some ways, in the sense that I think, one of the key things that I do when I'm talking to those kinds of audiences, any audience, medical audiences, or technologists, software developers, one of the things I do is make sure that I very clearly demonstrate with evidence, right, why first that the thing I'm talking about exists, and then what the consequences of it are. And I have found that, in those contexts, I am able to get the message across, and that people want to engage with it. I do think it can be easier to dismiss or reject a reading than it can be to do so with a person that you're face to face with and who you are having a dialogue with, right? It's true. The other thing, though, that I do that I think is really important is try to understand what their stakes are in the argument that I'm making. Like, what is the consequence of me saying, you must take account of emotion in your data collection efforts? Like, how would that actually play out in terms of changing the way that they do their work? Because I do think that, part of the responsibility, if I'm going to say, like, I actually really want to intervene in the way that you do your work, then I do think it's a little bit incumbent on me to think seriously about what that might look like, and to kind of facilitate that process, right? So I think that making sure that I understand, for example, like, what are the key constraints that they're concerned about, and use that to think about, well, so what interventions could I propose that might even be viable in this context? I think that's really important.
Great, awesome, thank you.
You're welcome.
Karen.
Okay, thanks so much. And thanks, Kirsten, for this really inspiring and brilliant talk. Much of what you discussed in your presentation, or how you framed narrative in your presentation, were shorter narratives. So as you said, telling stories in hospitals and so forth. And my question relates to, what about the narratives that are likely to be written in the years to come? So say literature, I'm a scholar of literature, longer, messier, even more ambiguous narratives, which, as you noted in your response to Jay, are not that friendly with data or AI. And so I just, want to pick your brain a bit and think about, I'm a scholar of literature. I work, on East Asia, South Asia. I actually was living in Korea and Taiwan during SARS in the early aughts. And it was a completely different experience from here. I mean, mask wearing there was long established. You have a cold, you wear a mask, so it's no big deal. Anyway, so, I teach literature and medicine courses and so forth. And so I'm really curious to see what kind of literature is going to come out of this. Maybe a lot won't, but I think a lot will. And so what I'd like are your insights into, how scholars of literature, students of literature, going forward, the insights that we can bring to data on COVID, or, really any disease. But I'm because I see how, your work so beautifully brings together data on, like the hard numbers on COVID and narratives about COVID, and really shows us just how one can inform the other and the importance of the humanistic approach there. What I'm thinking is going forward, when we're dealing with even messier, memory and all that, how do you see data fitting in? How can, we as literature scholars shape the conversations and so forth? So I know that's a really broad question, but any insights would be most welcome.
Okay, so a couple things come to mind. One thing is, I would really like to encourage more scholars and students in literary studies to really grapple with the tools that computer scientists are trying to develop for interpreting text, interpreting unstructured text, like natural language processing and stuff like that. It's also, it's being deployed in a lot of places, like on electronic health record systems, like for the unstructured narratives there, but also, they're trying to use those in education, like to grade papers, and, and they are trying to get them to be able to, recognize emotion as well, and all these other things. And part of the reason that I really want more literary scholars to engage deeply with that is to be able to look at the longer narratives, like you're describing, say maybe novels that, that come out of this, and put them into dialogue with other large data sets to be able to show what comes through and what doesn't come through. And, so that we can actually have like a robust, but also very grounded in the materiality of what both sides are trying to engage with, right? Like large bodies of text. So you're trying to get something very different out of those bodies of text than a computer scientist might be, who's trying to, code it, say, in some way, or develop an algorithm that could code it. But both, if you accept the premise that both approaches can be valuable in certain circumstances, right, then I think that we need to really kind of crystallize, what do you get out of the kind of reading that is able to sort of illuminate the messiness of, say, the narration of memory, in a long narrative form, that, and then ask yourself, like, what if we assume that actually real people in the world who are the sources of data also have messy narratives and in their memories, yet those memories are like producing data that becomes part of a data set, that becomes part of a statement of some objective fact about something that occurred, right? So I think there needs to be a lot more dialogue back and forth about, about those kinds of questions. And I think that not to say that you only have to look at literature through the lens of, computer science by any means. And, but I feel like this is kind of an evolution of the whole distant reading, discussion and debate from several years ago, because now it's not the question of like, how do you read 100,000 books to write an article about it, but rather like, how do you look at literary expression as a form that can contextualize data, and be in dialogue with it in some way. So I would want to just frame the questions that we bring to literary analysis more through that lens. I don't know, does that help? Does that make any sense?
Oh, it completely does. It really does. And, I'm thinking of my own work in medical humanities and all that. And I think I do that on kind of an abstract level, but I love how, just precise your own research is. And I think if, we can bring some of that precision, sort of combine some of that precision with the messiness, I don't know, I think we can do good work in this area. So anyway, thank you. Thank you so much.
Thanks. Thank you.
Fantastic. And Chris.
I won't sound terribly original by now thanking you for this. This was just wonderful, but I mean it all the same. Sorry, I'm kind of going like perfectly in a sunlight moment. Anyways, so I had a question. I think it actually builds off of a number of things that the previous folks have asked, but I wanted to ask you a little bit more explicitly. I was just thinking, and particularly when you talked about data feminism in the Journal of, what was it, Big Data and Culture? Was that the?
Big data and society.
Society.
Yeah.
So for me, the experience of 2020 was waking up and looking at the COVID dashboard, but then also immediately flipping to 538. And I kind of lived pulled between, like, am I going to die of COVID or am I going to have to flee the country? But so I'm just kind of curious, especially as you answer these questions that point more towards like computer science, as opposed to something more specifically health related, or so I'm just wondering the extent to which, both either in terms of pedagogy or your research, what health as a qualifier adds to this, as opposed to thinking about this as a data humanities or data story. Like, is there something particular here to health and medicine? Or I assume there is, but like, and as I said, either as you're trying to teach these skills to people who are going to make these algorithms, or as you kind of trying to disseminate your research, the extent to which you're in dialogue with kind of more just, I don't know if data humanities is the right word or is it a thing, but I hope you get what I'm pointing at.
Yeah, I do, for sure. And I'm certainly engaged with that literature, to be sure. Like, that's not necessarily just related to health data, for example, but like in digital humanities and that kind of stuff. I think there are a couple of things that make the health context unique. And so I think one is the stakes are very high, right? The stakes are different in healthcare. Whether, getting it right can literally be the difference between life and death, right? And that isn't true in all circumstances. Though I think about kind of the health implications of this really broadly. Like, I think that you could take everything I said today and then add on a section about what this means for how we think about human health in the context of climate change. And like, a lot of the same stuff would kind of apply, and there would be, and I think in particular, like the part about translational humanities methods, I think is very, very much like that's one of the sort of fields of application that I think is really critical and is totally interwoven here. But so the stakes are very high. I think that's one thing. Another is that the ways that that we associate are thinking about health and say like privacy and trust and things like that. It dovetails with a lot of other things. Like, it dovetails certainly with race, for example, and with being part of a marginalized community, which isn't only relevant in the healthcare context, but it shapes those narratives and what's done with them in a way that, again, I think has a certain weight that is just not equally distributed. And one of the consequences of that is that there are a lot of stakeholders who have very strong investments in how either data or narratives are used. So, all the tech companies who are not known as health technology companies, like Amazon, for example, are absolutely getting in, and have been for a number of years, but even more so now, getting into healthcare. And so it's like, there are things that you can do with analyzing Amazon and its impact on culture and society, for example. But when you get into the healthcare context, there are particular implications. In terms of trust and privacy, there's a whole other layer of regulation that shapes what happens in ways that are not always good for patients, actually, and that sometimes create loopholes that make it easier to exploit the data that's not officially medical, but that's very health relevant. And that is where all this stuff about developing AI, I mean, Google is the biggest player in AI, and they also are all about getting into medicine and healthcare right now. So, you could look at Google and AI and what they're doing in all kinds of sectors, but I think the kind of implications are different, both because of the stakes, the sort of human mortality of it, also because of the regulations, which are different from really any other sector, and because it is seen as a sector that is an opportunity for a lot of very rich data that also can produce a lot of money. So like all of those things I think are kind of at play there in a way that different dimensions of them may be at play in other sectors, energy, for example, but just not on the same way that sort of spans kind of the very, very intimately personal with the kind of like human need also. So I think that's probably another piece of it, is just the fact that, you know, it's a space where we feel compelled to tell stories. We have stories. When we have those encounters, they do produce stories. But also we are really beholden to those encounters in the sense that we need them. Like when we need them, we need them. It's not a choice. Like, am I gonna actually get medical care, or am I just gonna like decide that that's not important to me? I mean, that's a spectrum, right? But when it's like a crisis, you know, that's where you end up. So I don't know if that's fully answering your question or not. Did I touch on it a little bit?
No, absolutely. It was actually just something that kind of, I hadn't twinned those in my head until you were talking, and I realized like that on one hand, I understood the political numbers I was looking at to be fallible, constructed. There's been all these lengthy debates about like what goes into these, how much can we trust them, and so I was just kind of I haven't found those conversations kind of publicly twinned necessarily, and so I just I'm grateful for that. Thank you so much.
You're welcome.
So I think I might actually take the interlocutor's prerogative and ask a last question, if that's all right. So, you know, one thing that occurred to me, and maybe it comes from being in an English department where we have, you know, people who actually, I think English departments actually are sort of weirdly occupied by people who do very different kinds of work, especially especially ones that have composition and rhetoric and literature and creative writing, and those things, you know, are all sort of vaguely orbit around the same things, but actually sometimes produce really different sort of orientations toward things. And so, you know, in that context, I was thinking about the use of narrative specifically as opposed to rhetoric. And so I'm asking the question in part, I totally know that I say this as a literary scholar. So I'm totally with you about, you know, storytelling and the human need to produce narrative, and the ways in which narrative helps us make sense of the world, and that we understand the world in narrative. I fully buy all of that. I suspect maybe some of my colleagues who work in composition and rhetoric would say, you know, rhetoric really is the thing that we need to be paying attention to, and in the talk, I was attuned to the twinning of narrative and emotion, and I guess, like, I would say, you know, from my own intellectual standpoint, I'm a little uncomfortable with that, as not that you were saying this, right, but as the only sort of value of narrative, right? Although I think you were also saying it was individuating. So this is totally, I guess, maybe a little bit selfish, because I instinctively totally agree with you that narrative is the place we need to look, and maybe it's just because of narrative medicine that it's sort of narrative and data are the two terms that are twinned. But I'd love to hear you say more about other ways of looking at language, and why narrative and not something like rhetoric.
Yeah, that's a great question. I mean, it makes me think again about how large data sets of unstructured text are interpreted, and in the development of software to do that kind of work, linguistics is often brought in. So I don't know, to me, I would put linguistics and rhetoric a little closer together. And in terms of thinking about just like the structure of language, right? Like the structural elements of text, of narrative, which is what you have to do if you're trying to develop a code whereby you're not looking at the holistic meaning, you're breaking it into chunks and assigning meaning to those chunks, and trying to do so in a way that is somewhat faithful to at least the like one layer of meaning of the whole string of chunks, but it's not necessarily the same meaning that you would get if you read it as a narrative, for example. So I think it's important to actually be aware of both of those levels, because it can illuminate what might get lost in between them, in the sense that the more that you treat language as a structure, the easier it will be for you to produce an algorithm that can interpret that structure. But the extent to which that will lead to an accurate interpretation of that is a whole other question, including on the level of, the so-called emotion. I mean, this is also something that people are trying to encode into algorithms, the ability to, do sentiment analysis, right? So if a certain set of words are near each other, that means like a positive emotion. And, there are many easy examples of how that falls apart. But the thing is, these efforts are not going away. So like we can be dismissive of them and they'll go on without us, or we can, engage and kind of try to produce efforts that actually, take seriously that you can learn certain things from looking at language as a structure, right? Of course, like the literary studies has an illustrious history of doing just that, but that's not where things ended, right? So we have moved on from there, but it's not like we have completely jettisoned all of those insights too. So I think in some ways, I mean, I don't know if a rhetorician would agree with my alignment of rhetoric as closely with linguistics or not, but I do think that at least on the level of thinking about it in terms of structure, there's a way in which that it does make sense. And so I think that then the question of how you pull the sort of the less tangible elements out of a narrative that may be very, very meaningful, but that are kind of hard to put into like just one or two words, say. The question of like, how does that appear and register and become like communicable in a context where then that same narrative is also being kind of chopped up into bits. Like, I think that tension is something that needs to be explored further. So I think there's probably a space for new methods that kind of cross in between those different approaches.
Well, that was fantastic. And I think it speaks to the richness of the talk that it's 6:05 and we've kept you on now for over your hour and a half. So thank you so much for coming and speaking with us. This was just fantastic. And I hope you'll all join me in thanking Kirsten Ostherr for coming to talk to us today.
Thank you. It was my pleasure. Thank you all for coming. Great questions too.